This is Rory Spiegel and Ryan Radecki. This is the Annals of Emergency Medicine. It is March 2020, and we are coming to you from the inside of a pandemic. Ryan, how you doing?
I'm doing fantastic.
So we were all ready, set to record probably about 2 to 3 weeks ago, and then everything fell apart, I think is the easiest way to put it. And I think we've both been stuck in 4 or 5 COVID meetings a day, plus our clinical shifts. And needless to say, we're a little bit delayed.
And if by a COVID meeting you mean trying to get my 3-year-old and 5-year-old to stop biting each other, then yes, that is my new life. When I'm not
Yes, yes.
working, that consumes 100% of my free time.
Plus take that plus the 7 Zoom COVID meetings I have every hour. That sums it up.
So we'll definitely talk a little about COVID at the end because I think that's probably what's on everybody's mind. But we do have an issue of Annals, and we should probably really run through that one at least a little bit, just to talk about what's important in what just came out.
All right. Well, why don't you hop right in?
Sure, I'm just going to talk about a few articles here that came out. One's called Inhaled Methoxyflurane Provides Greater Analgesia and Faster Onset of Action versus Standard Analgesia in Patients with Trauma Pain. This is the INMEDIATE, a randomized controlled trial in emergency departments. And it comes out of Madrid, Spain. And without going into too much detail, this is sort of a resurrection of methoxyflurane, a product not really available in the United States, but available in Australia and New Zealand. And this was a randomized controlled study trying to use it as an inhaled anesthetic in trauma patients. It's a sponsored study, and it seemed to benefit patients a little bit as far as comparison to standard analgesia. But their standard analgesia arm was, IV tramadol, non-opiate analgesia, and their follow-up time frame is 3, 5, 10, 15, and 20 minutes. So I don't know exactly how this would possibly work into a workflow, other than sort of like the loading dose, maybe, to be all you're getting other stuff on board. Little suspicious based on this funding source, but it's a little bit hard to figure out exactly how truly useful or efficacious this might be.
Yeah, I think, most of the time our problem isn't with the current pain medications we have, it's just how we use them. And I think if you use them right, we probably have sufficient pain medications to achieve proper analgesia. Just often they are used incorrectly or inappropriately.
Yeah, I mean, I can get somebody out of pain within 20 minutes of their arrival, no trouble, if I use appropriate doses of IV pain medications. And the side effects of this were not trivial. There's some interesting words in here. Verbigeration, a new term, obsessive repetition of random words and phrases, somewhat similar to perseveration. They actually saw a few patients with that in this study.
Interesting. All right. So our next article, the evaluation of non-fatal strangulations in alert adults. And the lead author is Aaron Matus. So what do we do about patients presenting to the ED following strangulation, or by either manual or near hanging? If these patients look well with no obvious signs of airway compromise, how many of them are actually harboring cryptogenic injuries? And this is a real question. A lot of them have bruising across the neck. And I don't know about you, Ryan, but I often worry about the risk of carotid or vertebral dissection. But we don't really have great data on how to risk stratify these patients. So these authors conducted a retrospective analysis of alert patients presenting to the ED after a non-fatal strangulation. They enrolled trained research abstractors blinded to the imaging results, collected data on patient demographics, presentation vital signs, year of injury, initial GCS, so on and so forth. Overall, the authors identified 349 patients who met their inclusion criteria. The vast majority of these were manual strangulations, 328, and only 21 were near hangings. Only 60% of the cohort received advanced imaging. A total of 6 patients, 1.7%, had any injuries, including 1 near hanging and 5 manual strangulations. 2 injuries were clinically important, so the rate of 0.6%. Both were in the manual strangulation group, and both were cervical artery dissections treated with aspirin. Neither of these patients developed neurological symptoms. No patients reported to have missed injuries in the next 30 days, although the loss to follow-up rate was about 15%. All patients with injuries had abnormal symptoms or findings.
Yeah, I mean, I think that basically sums it up nicely. And then the authors actually say, although the current study adds only minimally to the existing literature on near hanging victims, I think that basically sums it up in one line. Nothing here really specifically predicts who's going to have a blunt cerebrovascular injury. And then they actually have an interesting bit in their discussion about, we did detect these injuries, and the treatment is aspirin. But again, the aspirin decreasing the event rate at 1 year is really only a minimal improvement as well. So did we really have to were those important injuries that we picked up even, and did we actually prevent any downstream strokes because we picked them up? uh, and they do sort of like this little brief little sort of like what was the value of picking up these injuries versus the risk for downstream cancers or the cost of CT. um, Definitely another interesting question to get into. I look forward to finding more prospective and better data to try and predict which patients certainly we could forego scanning in.
Yeah, I mean, I think the big problem is here is the gold standard is actually finding an injury, and there's often reports of institutions that do pan scanning and contrast studies in all trauma patients and find a whole bunch of these, and they tout that as the fact that they found all these injuries that they treat with aspirin and everyone we avoided strokes in. But if you think about it, there wasn't a huge problem of all these patients suffering massive strokes before we started pan scanning all these patients, and so you often wonder how many of these injuries actually occur and are clinically meaningless and how much we actually have to treat them.
Yep. I'm not sure we're ever going to know
No, no.
specifically, since although we could randomize patients to, kind of like we're trying to figure out whether subsegmental PEs are actually clinically significant, et cetera, et cetera. Um, Another study in this most recent issue, the Australian Injury Comorbidity Index to Predict Mortality, comes from D. Thuranga Fernando at the Monash University in Victoria, Australia. This is kind of one of those important for research, not so much important for clinical care, but trying to come up with a good descriptor of comorbidities and their influence on outcomes for trauma research. Not so much because when you have a big cohort of trauma patients admitted, they bring their own risks of poor outcomes with them, independent of the traumatic injuries that they've sustained. So this is sort of them trying to come up with another data set to make adjustments for future analyses.
And how did they do?
They came up with their own area to the curve of about 0.92. And whether it's generalizable to your specific trauma data set when you're doing research, you'll have to read it and find out.
Yeah, I think that was my take too. It seemed like they said they did pretty well, whether it's actually translatable to outside of the two cohorts they used it in, I'm a little unclear of. All right, so our next one, prevalence of intracranial injury in adult patients with blunt head trauma with or without anticoagulation or antiplatelet use. The lead author is Mark Probst. And so I think this was a really nice and important study. It was a multi-center prospective observational trial where they enrolled patients in 3 emergency departments in the US and looked at adult patients who took antiplatelet or anticoagulation, who had head trauma and underwent neuroimaging. They documented the pre-injury use of aspirin, clopidogrel, or warfarin. Data on direct oral anticoagulation was not specifically recorded, which at this current age is probably a big disadvantage of this study. They enrolled over 9,000 patients. The median age was 53. About 60% were men. A total of about 14.6% were receiving some kind of antiplatelet or warfarin in this trial. Compared with that without anticoagulation, the relative risk of significant intracranial injury was 1.29% or 1.29 for patients receiving aspirin alone, 0.75 for those receiving clopidogrel, and 1.88 for those receiving warfarin alone. The relative risk of injury was 2.88 for patients receiving aspirin and clopidogrel in combination. And so, this is reasonably consistent with things we've seen before. It is surprising that clopidogrel alone did have the lowest risk, and it was consistent across all groups. There's a number of important subgroups that I think are worth looking at. We don't so much care if everybody was head injury. The ones that have clinical signs of intracranial bleed are pretty easy to detect, but the ones with a GCS of 15 who are neurologically intact, in that group, the risk of intracranial injury was significantly lower. Overall, it was less than 1%, and it was about 1.5% in aspirin. And it was pretty consistent across the groups where you saw a little more in aspirin, a little less in clopidogrel, more so in warfarin, and then increased risk in patients on aspirin and clopidogrel and warfarin and clopidogrel. The problem is when you look at these subgroups, there's some of them are so small it's hard to really know what to do with. For example, in the warfarin and aspirin group, there was only 39 patients and one actual intracranial injury, so it's hard to actually make anything of that. And the biggest, I think, limitation of this paper is it doesn't actually look at one of the things we're really concerned with all these drugs is the risk of delayed bleed. So if you have a negative scan, what is the actual chance that sending this person home and they will have a bleed down the line that you don't pick up?
Well, we already know that it's really hard to pick up those delayed bleeds, anyways, and hard to predict those delayed bleeds. Higher INRs are worse, obviously, but difficult to pick up. But we should also be clear that the prevalence of intracranial hemorrhages are very similar across all groups. I mean, yeah, twice as frequent in warfarin monotherapy, up to 7%, but it was also 4% in the no coagulopathy group. So it's a big relative increase, but it's still a very small absolute increase, and it's still a pretty low yield CT scan. So I know there's at least some research moving forward to try and tease out specific predictors of having a abnormal CT, so that we don't necessarily have to do CTs on every single patient who has either clopidogrel or warfarin on board.
Yeah, well, that was my concern. My hope was that if your GCS was 15, you were neurologically intact, these risks would be really low and you could probably forego scanning. And that may actually be the case. So in subgroups, it does get up to the point, a risk high enough that you probably should actually do the head CT.
Oh, for sure.
All right, moving on.
Yeah, and the next one is called "The Effects of Global Budgeting on Emergency Department Admission Rates in Maryland," and their lead author here is Jessica Galarraga. And this is kind of a very interesting sort of public health policy article because Maryland does its own thing. They have always had this sort of payment model built on set units of service and sort of its own individual cost review commission. And at some point, it was working until it didn't, and the costs eventually exceeded the essentially their state budgets, and so they developed this sort of capitation system where each hospital gets a certain annual cap of revenue for all hospital-based care. So this is sort of a retrospective look at what happened when they sort of capitated care and the costs of care. Did it impact downstream emergency department admissions and sort of the frequency of resource utilization? And the answer is maybe a very small amount, very small decrease in ambulatory sensitive admissions and global admissions were observed based on this change in payment structure. So there probably is a little bit of influence at a systems level when you change the way that hospital systems function. There is probably some observable pressure on the emergency department to not admit patients, but this study does not go into precisely how those mechanisms worked.
Nor does it go into if it was an appropriate drop in admissions, right? Like, were they actually not admitting the right people, and how did it actually change patient outcomes? Obviously, the granularity of the data isn't good enough to do that. And while it was statistically significant, I'm not really sure a 0.6% change in admission rate is clinically important. But again, it's hard to know with the limitations of the study.
Well, I mean, and it's not like it wasn't confounded. I mean,
Right.
there's so many different types of, so many different factors influence whether a patient is being admitted, as far as medical culture is going, and insurance coverages and different things. So it's not just the global budgeting and the capitation that influences whether patients are chosen or selected for admission versus discharge.
Right. It's fairly complex. All right. So our
Fairly
next article,
complex, they say.
to say the least. All right. So our next article: impact of urgent care openings on emergency department visits in two academic medical centers within an integrated healthcare system. The lead author is Lewis Carlson. And so once again, we're going to take a look at, do the opening of urgent care centers around emergency department decrease the low acuity visits to those emergency departments? So these authors conducted a rather complicated geospatial analysis of two academic emergency centers as integrated urgent care centers were opened around them. And they looked at how this affected emergency department visits, to find how this affected low acuity emergency department visits based on ED discharge diagnosis, urgent care center proximity, and the actual proximity of the patient to the center versus the emergency department. So, what they found a statistically significant reduction in the likelihood of an ED visit for a low acuity condition in patients living within 1 mile of an urgent care center in one of the two academic medical centers, as there was a reduced odds ratio for an emergency department visit. However, in the other emergency department, there was no statistically significant reduction in low acuity visits. Further analysis showed there was a temporal relationship between urgent care center opening and the likelihood of a low acuity visit, with approximately a 1% decrease in the odds of low acuity visit for every month that the urgent care center was open. So, like all the other articles we've seen on this, I'm not really sure this offers convincing evidence that urgent cares actually reduce low acuity ED traffic. At one site, there seemed to be no change. In the other, it seemed there might have been a very small reduction. We've seen previous cohorts that we've actually looked at on this podcast that opening an urgent care didn't change ED numbers at all, but rather create a new population of walking well patients who wouldn't expose themselves to the hassles of an ED visit, but may go to an urgent care center if it was convenient.
Well, I think that's clearly what you see here. I mean, the odds ratio of a 1% decrease in the odds of a low acuity visit for every month that the urgent care center was open next to it. Yet the urgent care center also has its own daily census, so it's basically a surplus of patients as opposed to any sort of like overall reduction or redirection of care.
Yeah, exactly. It doesn't actually accomplish what we hope it to accomplish, and it doesn't replace a primary care system in any sense.
No. And then the last one, is this the last one?
I
Or
have
do you
one
have another one?
after.
Okay.
Yeah.
And then the next one here is Google versus PubMed. Comparison of Google and PubMed search tools for answering clinical questions in the emergency department. This comes from Trisha Morshed. And basically, they just did a really quick comparison to basically how we all teach ourselves on shift when we come up with clinical problems that we aren't as familiar with or can't remember from the last time we saw a patient like this. And they basically looked at when you do some sort of a common clinical question and you go into just the Google web search, the Google Scholar search, the PubMed search, or the PubMed clinical queries search, and just looked at the first 60 hits to review the quality evidence produced. They compared them and said, well, you should probably use the PubMed clinical query search, but you will end up getting a fair scope of reasonably clinically relevant links with which to base your clinical judgment. Also thought Google Scholar performed well, in some cases receiving citations that even PubMed did not. Google Web was not quite as efficient, just the general search. So one step above your patients, if you can use Google Scholar or PubMed instead of just using the general Google search, you'll get better results, at least more clinically relevant results. I think the Google Web search, I think as we probably all can say anecdotally, gives you a lot more sort of layperson type articles, which may be appropriate for our patients, but not so much for us.
Uh, Part of me was really hoping that just a simple Google search worked just as well. That would be quite funny.
It's a lot faster.
True. All right, final article of the month: evaluation of spin in abstracts of emergency medicine. Evaluation of spin in the abstracts of emergency medicine randomized control trials, and the lead author is Victoria Reynolds Vaughn. And so we all know that there's quite a lot of spin and hype put behind a lot of articles published. In fact, Ryan and I have both been screaming into the void that is Twitter for many years now about various degrees of hype on various articles. But these authors wanted to quantify this hype. And so they looked at emergency medicine related randomized controlled trials from the emergency medicine literature from 2013 to 2017, looking at the top 5 EM journals as well as the top general medicine journals. They define spin as authors focusing on statistically significant results, interpreting statistically non significant results as equivalent or non inferior, using favorable rhetoric in the interpretation of non significant results, or claiming benefit of an intervention despite statistically non significant results. They identified 114 randomized controlled trials with reported statistically non significant primary endpoints. Spin was found in 44% of them. Not surprisingly, industry funded trials were more likely to have spin in the abstract than non industry funded trials. Spin was often due to authors emphasizing a statistically significant subgroup when the primary endpoint was non significant. And in the conclusion, spin was most often due to authors claiming they accomplished an objective they had not claiming they accomplished an objective that was not a pre-specified endpoint. So, for me, this is not surprising at all. We've seen this before, and I think there's a number of articles looking at this in general medicine. Well, it's not surprising that it's consistent throughout the emergency medicine literature.
Well, yeah, and I think this is basically just sort of research, how to read research 101 is that you can't just look at how the authors interpret their own study. You have to go back and look at the raw data yourself and come up with your own conclusions, because even if it's not nefarious and they're not trying to, self promote, a sponsored study, trying to spin it in a way that's, financially profitable for their, bottom line, each individual clinician who, performs a study and tries to publish positive results wants to focus on what they discovered, and it's not nefarious at all. It's just, their own specific, implicit bias and sort of presenting their results. This is why people are taught to read articles critically, so they aren't misled by the spin, and they're actually focused on the results and the methods, and come with your own conclusions as opposed to just listening to the authors.
I was just Do you think these authors put spin on their results? That would be quite ironic. No, I'm just kidding. They didn't. It was a great article.
We're going to incept this article. We're going to go down to the spin within the spin.
Dream within the dream. All right. Well, that wraps it up for what we found in this month's Annals of Emergency Medicine, and we thought we'd focus the rest of our time on talking a little bit about what's occupying everybody's mind in medicine these days, which is COVID-19.
Yeah, I mean, we've been, deep in COVID-19 for 2 weeks now, 3 weeks now. And there's been a lot published in the New England Journal of Medicine, JAMA, the Lancet, preprints, and all sorts of other sources. And we just thought we'd talk briefly about a few things that, are either controversial or are going to impact your overall survival, specifically healthcare worker overall survival.
So I think the first thing we should talk about is how sensitive and specific are the actual tests that we're using to diagnose COVID.
Yeah, I mean that's kind of the tricky question. Is when these are PCR based assays, they have their specific primers and probes based off of RNA samples from the virus itself, and these are great primers and probes, and they will detect the virus accurately, and they're really really specific and really really sensitive in the laboratory in a controlled setting. The difference is, what do you do when the difference is between that laboratory, that analytic sensitivity, and the clinical sensitivity. And we have a couple articles, one in the Journal of Radiology that talks about 1,000 patients from China and sort of what their criteria were for diagnosis. And if you recall, they were using CT as an additional criteria for diagnosis. And the question you would come up with is, why do they need CT? It's because the nasopharyngeal swabs are not sufficient.
So just as a reference, this was correlation of chest CT and RT-PCR testing in coronavirus disease 2019, COVID-19 in China, a report of 1,014 cases. So what'd they do?
I'm not doing like a review.
Just give us a little.
No, I'm not going to do a methods thing on these. I'm just going to talk about them.
All right, talk about it.
We're just going to chat. This is chatting.
Right,
this is not
chat.
analytic. This is not journal club anymore. This is not breaking it down. I just want to make sure that these people know. I mean, I'm just going to say that. I'm just going to get Jeff someone to say. So what they like? I'm not going to say what they do. I'm going to say what did they find. I'm like,
all right, I'll say. So what did they find?
So, I mean, if you want to just look at the key points, I mean, so their positive rate for their PCR assay was 59%. So 600 patients out of their 1,000 had positive PCR. And then another 88% had positive CT chest imaging. So basically, their combined gold standard, basically, they would call them the sensitive chest imaging as 97%, but much, much lower with the PCR, 60%. Serial assays, put more than one assay together at a time, you can get higher sensitivity. But I think this is a real concern as far as making sure that we're not unnecessarily exposing ourselves to patients who have coronavirus. You cannot rely on the nasopharyngeal swab to rule it out.
Yeah, so I mean, I think this study helps us in a couple ways. My issue was the gold standard was the PCR testing, and so the CT scan, and that included early PCR testing or late PCR testing. So the CT scan had a really poor specificity because there was patients who had a negative PCR but a positive CT scan, never got a second PCR, and so that was considered as negative. We know from other studies earlier that the PCR, like you said, the initial one isn't that great. 60 to 70% sensitive. And so some of these patients might actually have COVID-19, and we just never were actually able to identify them because they never had follow-up testing. So I think the take home you can take from this is, one, the initial PCR isn't perfect in any way. And if the clinical picture really looks like COVID, you should treat it like COVID. But there's also the more these patients you treat and the more the emergency department starts going COVID crazy, anything that comes into the emergency department gets called a PUI. And the problem with that is, you have to put the hospital has certain criteria where you're putting these patients, and that is obviously changing as the hospital fills up. But initially, you're trying to put them in some kind of isolation room for droplet or airborne precaution, depending how sick they are. And if everyone's a PUI and you have to wait for your COVID testing to come back to clear them, you're just going to fill up beds needlessly. And so a negative CT scan in a low risk patient, so someone who's sick but doesn't have the real symptoms of COVID-19, may be good enough to say, I don't think this patient needs a room that is a negative pressure room that we're going to have so few of and are filling up with these patients.
Yeah, and this goes back. I mean, we've known this for decades. I mean, the original SARS CoV-1, the original when they did their analysis of the sensitivity of those PCR assays versus serologic, IgM and IgG, IgG and IgM markers, which have their own limitations as well. That they thought that kind of test was only 60 to 70% sensitive as well. Um, if it would be really nice to be if you look at what they did in China, we can't replicate it. They would do two RT-PCRs. Like, this is what they eventually did in Shanghai, like, as their like gold standard to try and prevent spread and to maximize the sensitivity, is they would do a chest CT, two swabs, and then send high pretest people for like next generation sequencing
Right.
of samples to make sure they didn't miss anybody, because they really wanted to ensure contact tracing, ensure they 100% rule out sensitivity.
Right. And they had these
Obviously, with our cobbled
hotels.
together healthcare system, sort
Yeah.
of like, we can't even test anybody in the emergency room who's going home right now, depending on where you're at. It's hard to get one test, let alone four different tests.
Right, and then they had built, like, these hotels out of nothing in 10 days where the patients could stay in isolation until they were cleared. So,
Yeah.
yeah, because of our broken healthcare system, we're not able to achieve that kind of testing.
So, but yeah, I mean, the most important thing here to take away is, don't rely on that negative test to rule out COVID. Positive test, really useful. Negative test requires additional steps.
Yep, indeed. All right, well, why don't we talk a little bit of how long this virus survives on various surfaces and aerosolized in the air, a very disconcerting and scary little publication in the New England Journal. It was entitled "Aerosol and Surface Stability of SARS-CoV-2 as Compared with SARS-CoV-1."
Yeah, you probably read it more recently.
So, I mean, this is the big fear of all our healthcare workers. How are we exposing ourselves to this virus, and how long does it live on various surfaces? So, if you have a patient in a room and they cough, and droplets touch the counter, does it live in fomites, and can we get it by walking, 8 hours later and touching the counter and then rubbing our face? Is it actually transmittable at that time? Furthermore, the big fear is aerosolization, and how long does this virus actually live in the air, and are droplet precautions enough? And with our ever shortening supply of PPE, do we really need actual true airborne precautions when dealing with these patients at all times, rather just when we are doing aerosolizing procedures like intubation or bronchoscopy or so on and so forth? So these authors did a simulation study where they basically sprayed viral particles and checked how long they were viable for, and they did it in 5 environmental conditions: aerosolized particles on plastics, on stainless steel, on copper, and cardboard. And the results aren't pleasant. The virus lives for a very long time. Essentially, it does less so on cardboard and copper, but on steel, plastic, and in aerosolized form, it can survive for quite some time, up to 72 hours, which is somewhat disconcerting.
Yeah, I mean, in my mind, that means just please, please, please thank your environmental services workers for doing an amazing job at cleaning all these rooms for PUIs, if they're being, and your shared spaces. Uh, Mostly, it's important for decontamination of yourself, thinking about what you're wearing in and out of the hospital, making sure that you're not taking anything into your home, touching surfaces that you're going to retouch again. This is ways to prevent spread to yourself and your other staff members, as well as implications for decontamination at the hospital. But this is where this is what I take away as, like, how do I protect myself from these sorts of different things? Do I need to absolutely making sure I'm wiping down everything when I'm coming in and out of the hospital, which I expect most people are already doing at this point.
Yeah, I mean, this was a simulation study, so it's somewhat hard to know exactly what to do with it. But I think the take home point is this virus is everywhere. Um, there was another study that's actually not for true publication yet. And one of the interesting things about COVID is people are just releasing their data before peer review. And there was one done out of Nebraska recently where they were able to sample it out of the air and culture it outside negative pressure room about 4 feet away from the door. So, uh,
Yeah, and there's a similar one from Singapore that was also published, I think, either yesterday or the day before, that shows similar things. When you suck it in with one of these like air samplers, you can find virus, for sure. You can PCR the virus, but it's a question mark still remains whether it's a viable infective virus. There's a
right. I
difference
think
between live virus and then RNA samples that you can amplify. So
Yeah.
they're definitely finding RNA samples you can amplify, but they haven't been able to really demonstrate that it's infective. Aerosol, like in this study, was the half life was an hour, so you
Right.
can get it dies pretty quickly in air, but it's still there for at least a brief period of time.
Yeah, and then the question is, how do you apply that clinically? Does that really, if it's there in the air for an hour, does that mean you have to wear full airborne precautions for every time you enter the room? It's pretty unclear what we actually do with that.
Oh, I think it's actually really clear. It means you absolutely have to cohort your patients who are PUIs in one unit, and the people who are taking care of those patients in that unit wear full N95 face mask gowns their entire shift when they're working in that COVID unit. I think that's what people are doing in Nebraska. That's what people are moving to for their inpatient COVID units, and that's probably where, if you're cohorting patients in your emergency department to a specific area, your staff should probably be wearing full PPE for that entire shift.
Yeah, and I think that's as we run out of PPE, that becomes a bigger and bigger deal.
Yeah, I mean half lives are small, but if you're going in and out of rooms and those doors are opening and closing, it puts the entire staff at risk every single time.
Sure, and this is
And
a
we don't
half
have
life.
negative pressure rooms for everybody. I
Right.
mean, we have like one or two. We were
Right.
ready for like the single Ebola patient who showed up or something like
Yeah.
that, but we're definitely not ready for an entire unit worth of SARS.
Yeah, and remember, this was a single simulated spray. This is not a patient who's in there continually spreading virus.
Oh yeah, the
So
patients are
yeah,
definitely spreading virus. I mean, they sample the surfaces in these places and they're just covered in virus. So every time you flush
right.
the toilet, it covers the entire room in virus. I mean, our environmental services people should all get medals at the end of this.
All right. Well, why don't we move on? Why don't we go to treatment a little bit?
Oh my god. So what are the treatments?
Well, you
Is
tell
there
me. What do
any
you
limit
got?
to what we could possibly use to treat them? I mean, you look at these Chinese studies and they use immunoglobulin, they use corticosteroids, they use oseltamivir, they use everybody's getting a bunch of antibiotics. And then of course you have quote unquote Chinese traditional medicine, which isn't always very well described in these studies. And then the big question, which is being is hydroxychloroquine and azithromycin.
It's the cure. The president said it's a cure.
And Rudolph Giuliani says that it's an amazing miracle drug that everybody should be taking. And
Yeah.
the problem is people are trying to. We're seeing all these anecdotal reports of pharmacies getting physicians calling in supplies for themselves and their families, which is at the minimum highly unethical and even worse, probably extremely dangerous.
Well, why don't you tell us what the data actually says?
Oh, we can all talk about the data, but so basically, there's multiple different little sources of data. A couple different tiny trials from China, 30 and 60 patients each. There's a little, which is basically 15 and 30, so like a whole grand total of 100 patients from China, showing really inconclusive results. Those are it's a little hard to they're preprints, they're not peer reviewed. Maybe some small signals of increased pneumonia clearance or potential clinical improvement, but again, really low quality data. Those are not the studies that people are citing when they're getting really excited about hydroxychloroquine and azithromycin. They're basically all citing these two studies from this group in Marseille, France, where they did sort of this uncontrolled two-arm hydroxychloroquine azithromycin pilot study with historical controls, basically, where everybody got better. And then they expanded this to 80 patients without even a specific control group, and just said, well, everybody who completed this treatment protocol got better except for like one patient. These are absolutely the lowest quality of hypothesis generating studies, with concerns for survivorship bias, reporting bias. Uh, there's no oversight, and what's worse is that this is a major hospital that clearly has the ability to do quality research and randomize patients and actually give us some insight into the actual efficacy of this drug, but instead they've just gone ahead and just published these really detailed case reports. If we could randomize patients to these two drugs, or even just one of the drugs, and actually see if this works and try and determine the population for whom it may have the best benefit, if it's even going to work at all, we could be we could I can't, I'm virtually speechless.
Yeah, you're getting really flustered there. I mean, a couple of things. One, the way they defined getting better was be able to identify the virus on a PCR, and less patients were you were able to identify a virus in the hydroxycobalamin or hydroxycobalamin in the hydroxychloroquine group. One of the things I thought was kind of funny was the loss to follow up. They had a bunch of patients lost to follow up in the hydroxychloroquine group, and some of the reasons they were lost to follow up admitted to the ICU or died. So that in of itself is kind of, it doesn't quite reach face validity, because you have patients decompensating in that group, and we're just taking them out of the group because they were simply lost to follow up because they
Yeah.
got sicker.
Well, they didn't complete the treatment protocol. They couldn't complete their 5 days of therapy. That's survivorship bias. If you don't complete the
Right.
treatment protocol and you die before the end of it, you're not counted as you don't reach the primary outcome assessment date. Then you fall out of the study. And that's this is this kind of thing this is a I just worry about.
Well, it's a tough gig, right? Like, so, I mean, speaking more generally, as we get deeper into this crisis, this is a really novel disease process that's presenting in a very novel way that I don't think we know or have any evidence on how to deal with. It's not ARDS. It doesn't present like traditional or previous viral pneumonias or viral lung injury, and so how do you proceed in a disease process that we have no real good data on and no real kind of previous experience on how to treat.
Well, I don't have any problem investigating all these various things. And there's tons and tons of machine learning models looking at different surface proteins on the SARS virus itself and trying to match it up with different mechanisms of action of different drugs and coming up with different hypotheses. And that's great. That's totally fine. But you shouldn't be doing it as just if you have the capacity to perform rigorous research, you should be doing that rigorous research for us to benefit all people, not just going ahead and having your own sort of salvage experimental case series and then presenting it like it's you've discovered the holy grail, which is kind of what's happening here. I mean, people are
Sure.
so desperate for some hope in this, in this madness. I mean, you see the mortality statistics from other countries, and you're sitting there, just in your self quarantine, or in your stay at home, work from home, shelter in place, just hoping to trying to find some ray of hope. And I can understand why everybody's so anxious about it, and I can see why people are using it. Because certainly at the point when you start to reach the point where the mortality from the disease starts to exceed the adverse effects from these relatively inexpensive, relatively safe medications, I can see why people would go ahead and try it. But if you have the capacity to test this in a rigorous setting and randomize patients, that's what you need to be doing.
But what about for the frontline providers here? What about me when I go to work tonight, and I've got 15 of these patients admitted to my ICU on the ventilator? How do I decide what to do and what not to do?
You just have to do your best. I mean, that's just true. We have so much uncertainty. I mean,
That's true.
we have clinical trials for the Gilead drug. What is that? I can never pronounce that one correctly. What is that one?
We should probably look it up and say it right.
Remdesivir or something like that. Yeah.
Uh,
So so we have clinical trials running with remdesivir. There's clinical trials coming through the pipeline for hydroxychloroquine. There's clinical trials probably coming through the line for a couple different immune checkpoint inhibitors. And if you don't have access to those clinical trials, then you just have to you're sitting there reading these preprints, with your critical care group, trying to come up with some protocol for your best guess or best hope for people who effectively are going to die. I mean, we're seeing really high mortality in certain cohorts. Once you get over 60 years old, or you start adding lung disease into it, we're talking about 10 to 30% mortality sort of
Yeah,
ranges.
I mean, once you're ventilated, the mortality in patients who are mechanically ventilated is 75 to 85%. It's crazy.
Yeah. So at that point, if you have something available, I mean, this is what happened in this vitamin C thiamine steroids trial. You have this really high risk, high mortality disease, and the treatment is relatively inexpensive and not thought to be tremendously harmful. Throw it at the wall and see if it sticks. And if you do this and it does seem to work, then report it. Hypothesis generating. Don't go out and hawk it like a carnival barker, but share your ideas with the greater critical care community and people. There's hundreds of clinical trials starting up and enrolling patients. We are the whole of the entire world is focused on finding treatments. You will find people who are willing to help you test a treatment if you can come up with a treatment protocol that you think might be useful.
All right. Well, I think that was a great way to end this. You're not passionate about this at all, I see. So I think that wraps us up for this month of the Annals of Emergency Medicine. Obviously, things are going to get different and more serious as we progress here. The actual kind of format of this podcast might change as we go forward. We'd love to hear feedback on what you guys want, what you guys need. If you want us to spend more time kind of reviewing some of this newer COVID literature as it comes out, we're happy to do that. We really want to be supportive for the emergency medicine community. Otherwise, we really want to say thank you to everyone out there doing this job. It's become more important than ever doing what we do. And we understand we're all putting ourselves on the line here. And so we just want to say thank you and stay safe. All right. Well, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.